Okay, let's unpack this. Today, we are dedicating this deep dive to, well, one of the most complex, most politically charged, and longest-running issues in American life, and that's the healthcare debate itself.
It really is. And our mission
Yeah.
today is to cut through all the noise,
Right.
to move past the sound bites, the misinformation, and really provide a critical look at the economic, the political, and the ethical forces that have been driving this thing for what, 100 years now?
100 years, and it all centers on this one core question.
Yeah.
What is the best allocation of resources to get the best possible outcomes?
And that framing resources, outcomes, and access, that's everything. This isn't just some abstract policy debate happening in Washington.
Yeah.
This is the actual mechanism that determines the quality of care people get, how costs are managed, and, whether people can even get timely access to services in the first place.
And for you, our listeners, especially those of you working in the health professions, understanding this whole debate, I mean, from the early calls back in 1912 all the way up to the Affordable Care Act, it's what the sources call a professional imperative.
Mm-hmm.
I really want to spend a moment on that, on professional imperative, because it's the why for this entire deep dive.
Yes.
The Institute of Medicine, they had this huge report back in 2010, The Future of Nursing, Leading Change, Advancing Health.
The landmark
It
report.
totally redefined the role of nurses in policy. It said nurses have to be full partners in redesigning the U.S. healthcare system.
Full partners, not just assistants or employees, but partners at the table.
Exactly. And if you're not fluent in what drives health policy, if you don't know the history, the scope, the resistance to change, you can't really participate in that partnership.
That's so spot on. I mean, policy isn't separate from practice. It actually defines it.
Yeah.
Think about it day to day. Policy decisions determine if your clients can afford their medication.
Or if they have access to preventive care.
Right. And ultimately, these decisions influence massive public health stats, including, who lives and who dies because of delayed treatment.
And for nurses themselves, it hits even closer to home. Policy dictates your scope of practice, what you're legally allowed to do.
And where you can work, and whether you can even get reimbursed for the advanced services you provide. It affects you professionally and financially. It all comes back to what happens on Capitol Hill and in state legislatures.
Okay, so let's pull policy right down to the bedside. Let's introduce a key concept that really came out of this cost crisis. Value-based purchasing, VBP.
VBP is so important to understand. It's basically the method the government uses to try and hold providers, hospitals, physician groups accountable for both the quality of the care they deliver and the cost of that care.
So it's a shift away from the old model.
A huge shift. The old model was fee-for-service. You just got paid for doing more stuff, more tests, more procedures, regardless of whether the patient actually got better.
Right, volume over value.
Exactly. VBP tries to flip that. It aims to reward the top performers and, well, penalize those with poor outcomes or really high costs. It's all about trying to reduce waste and inappropriate care.
So a hospital might get dinged financially if, say, too many of their patients are readmitted for the same condition.
Precisely. Or if their patient satisfaction scores are too low, or if they have a high rate of hospital-acquired infections.
And that immediately links VBP back to nurses, right? The source material highlights that VBP could use tools like the National Database of Nursing Quality Indicators, the NDNQI. What does that database actually track?
The NDNQI tracks what we call nursing-sensitive measures.
Okay.
These are outcomes that are really, really heavily influenced by the quality and also the quantity of the nursing staff.
So things like patient falls.
Patient falls, hospital-acquired pressure ulcers, catheter-associated infections, CIDIs, and even just basic nurse-to-patient staffing ratios. Adverse events and, yes, even mortality are highly dependent on having enough high-quality nurses on the floor.
So if a hospital does a poor job preventing CO2s, which is a direct measure of nursing care, that hospital is going to see a financial penalty under VBP.
That's the idea. And this just reinforces that fourth key message from the Future of Nursing report. We urgently need better data collection.
Because if these nursing-sensitive outcomes are now tied to multi-million-dollar reimbursement decisions,
Then we need the research to know what adequate and appropriate nurse staffing levels actually are. You can't just guess.
and nurses have to be at the table deciding what gets measured and how.
Absolutely. And this becomes even more critical when you look at the sheer increase in demand that the ACA was expected to cause.
Right, the projections were that 32 million new clients would suddenly need primary care,
A number the existing physician workforce just could not absorb.
which puts a massive spotlight on advanced practice registered nurses, APRNs.
Of course. And we have solid data on this. We know that nurse practitioners, NPs, can safely provide about 80% of the care a family practice physician does, with no decrease in quality.
And sometimes with even higher patient satisfaction, right?
Often, yes. Especially with preventive care. So you have this powerful, cost-effective solution sitting right there to close the gap.
But then you run smack into the political barrier.
You always run back to the political barrier. At the time the ACA was being implemented, you had all these regulatory hurdles that stopped advanced practice nurses from functioning to the full extent of their education.
And from getting paid fairly for it.
And that's the key. These are scope of practice regulations, and they're usually decided at the state level through legislation.
So you have this paradox. The ACA creates millions of newly insured patients who need primary care.
But state laws might stop the most qualified providers, the APRNs, from prescribing medication or ordering tests or even getting reimbursed in some places.
It's like building a highway but closing half the on-ramps. The system stays choked.
It's the ultimate feedback loop. This is why nurses, as the single largest group of healthcare providers, have to participate in policy. They have the credibility with the public. They're always rated #1 in honesty and ethics. They have to use that voice.
That sets the stage perfectly. Let's look at why this debate has been so tough for so long. Let's get into Section 1. And here's where it gets really interesting. We're looking back over a century, and this whole debate is just so deeply rooted in these fundamental American conflicts.
It really is. You've got the role of government versus the individual.
Regulation versus the free market.
And the big one, is healthcare a right for all citizens, or is it a privilege that you have to purchase?
And then, on top of all that, you have these incredibly powerful special interests just amplifying everything.
Oh yeah, big pharma, the insurance industry,
Yeah.
physician groups like the AMA. They're all intensely focused on protecting their financial turf. And history shows they've been very, very good at stopping or reshaping reform.
Let's walk through the presidential timeline, but let's really focus on the why of the failures. It starts way earlier than most people think. 1912, Theodore Roosevelt.
Yeah, running as a third-party candidate, the Bold Moose Party.
Yeah.
He was the first national political figure to call for national health coverage.
And this was right after Germany had already done it, so the U.S. was already behind the curve.
We were. But the first really crucial turning point in American policy came with Franklin Delano Roosevelt and the New Deal.
He thought about including national health insurance in the Social Security Act of 1935.
He did, which was just a radical idea for the time. But he backed down.
Why?
The American Medical Association, the AMA, their opposition was just fierce. They were relentless, and their messaging was incredibly effective.
That's when they started using the term socialized medicine.
Exactly. They used scare tactics that really worked in an era that was already suspicious of big government. FDR had to choose his battles, and he sacrificed health coverage to make sure he could get Social Security and his other big programs passed.
And that one decision was a massive fork in the road. It basically guaranteed that the U.S. would not have a single-payer social insurance system like almost every other industrialized nation.
But that era introduced another huge structural shift.
The one that defines our system today. The link between your job and your health insurance.
It all came out of World War II. FDR put in wage controls to stabilize the economy, so companies couldn't just raise salaries to attract workers.
So what did they do?
They used health benefits. Health benefits were exempt from the wage controls, so they became this competitive tool to lure in employees.
And just like that, a wartime loophole becomes the foundation of the entire system.
And it fundamentally separated the person using the care from the person paying for the care. The employer paid. That became the norm. And it created the system we still have today, a system that wasn't really built for efficiency or good outcomes.
The fight continued, though. Harry Truman, after FDR, he proposed a plan that was a lot like Canada's model.
A single-payer public insurance plan. He really believed in it. But again,
The special interests mobilized.
the insurance industry was terrified they'd lose their market, so they teamed up with the AMA. And they succeeded in scaling Truman's vision way, way back.
So it ended up only covering one group.
One very sympathetic group, the elderly.
Which brings us to 1961 and John F. Kennedy. He picks up that torch, advocating for a plan specifically for the elderly.
And his framework is what eventually led to Medicare.
But the big legislative win finally came under Lyndon B. Johnson in 1965.
Yes, with the passage of Medicare for the elderly and Medicaid for the poor and disabled. That was the most ambitious step forward until the ACA. It proved that government could step in and fill the gaps the private market was ignoring.
But it's so important to remember this wasn't just a Democratic issue.
No, not at all. A lot of people forget that. Richard Nixon, a Republican, he signed a law in 1973 to encourage HMOs, health maintenance organizations.
The first real version of managed care.
Right. It was an attempt to contain costs. And here is the really fascinating historical irony.
What's
Nixon actually proposed a comprehensive reform plan that called for a nationwide mandate for private coverage.
the individual mandate?
The individual mandate. He argued it was a matter of individual responsibility, needed to stabilize the market. This was a Republican free market solution.
That's incredible. That's the same concept that Mitt Romney used in Massachusetts decades later.
And it became the most controversial part of the ACA. It has deep bipartisan roots, even if it became a political football later on.
So after Nixon, we saw attempts from Carter, which failed. And then the big one in the 90s, Bill Clinton's Health Security Act.
Led by Hillary Rodham Clinton. And that was just defeated by this massive unified campaign from business interests and the insurance industry.
The Harry and Louise ads?
Those ads, they spent tens of millions of dollars to scare the public about losing their choices, and it worked. The failure was so complete that it led to a huge Republican wave in the 1994 midterms and basically shelved the idea of universal coverage for 15 years.
So the pattern is clear. Big ideas get shot down by powerful interests, and the root problems just keep getting worse.
And one of those root problems was how the insurance model itself changed from nonprofit to for-profit.
Let's talk about that. The original Blue Cross and Blue Shield plans in the 20s and 30s were nonprofits.
And they worked because of a principle called community rating.
How does that work?
Community rating pools the risk. The premium is set based on the average medical costs for a whole community or a whole geographic area. So the young, healthy people pay enough to help subsidize the care for the older, sicker people. It's a social insurance model.
But after World War II, the for-profit insurance companies came in with a different tool.
A competitive tool that completely broke that model. It was called experience rating.
And what's the difference?
Experience rating doesn't look at the community. It sets your premium based on your specific expected medical spending, your age, your job, your pre-existing conditions. The whole incentive structure just flips on its head.
So the for-profits could just go after the healthy people.
They can cherry pick. They'd go to a big company with a young workforce and offer them way lower rates than Blue Cross could, because Blue Cross had to cover everybody under community rating.
So experience rating was basically a way to bet against the sick.
That's a good way to put it. And the result was brutal and predictable. The nonprofit Blues couldn't compete. By 1955, the for-profit commercial insurers outnumbered them.
Which left the elderly and the chronically ill with either sky-high rates or no coverage at all.
Exactly. By the late 1950s, less than 15% of people over 65 had any health insurance.
And that systemic failure of the private market is what forced the government to create Medicare and Medicaid in 1965.
It had to. The market had failed them.
Yeah.
But even that had this huge unintended consequence.
The cost explosion.
Right. Medicare and Medicaid became this guaranteed massive source of income for the healthcare industry. And that money was just funneled into a system that still paid for more services, not better outcomes.
So you have guaranteed government money plus new expensive technology.
And you get a cost explosion. Healthcare costs just started rising 10 times faster than general inflation year after year. The whole system got geared toward volume and profit, not value.
And then, just before the ACA, in 2003, George W. Bush signed the Medicare Part D prescription drug benefit.
Which was a huge deal for seniors getting access to medication, but opponents pointed out a major flaw.
What was that?
The law legally prevented Medicare, the single biggest buyer of drugs in the world, from negotiating for lower prices.
That's staggering.
Opponents called it a massive giveaway to the drug companies. It was a huge missed opportunity for cost savings, and it just cemented this system's high-cost structure.
Okay, so that cost explosion wasn't just some number on a spreadsheet. It started to choke the entire American economy.
It did. And that brings us right into Section 2.
Yeah.
The overwhelming, multifaceted need for reform that finally led to the ACA.
And the case for that reform fell into 4 big categories: economic, societal, health outcomes, and some really profound moral and ethical issues.
Starting with the economic issues, the number that always just stops you in your tracks is the global comparison.
Yeah.
The U.S. spends 2.5 times more per person than the average of other wealthy industrialized countries. We spend twice as much as France, and they have a really high-quality system.
And the growth rate was just unsustainable. In 1970, healthcare was about 7% of the GNP.
By 2010, it was 17%.
17%. That's $2.6 trillion. Over $8,000 for every single person.
And the projection was that if we did nothing, it would hit nearly 20% of our entire economy by 2020. I mean, that's just an enormous claim on our national resources.
And that money has to come from somewhere. It means less money for education, for infrastructure, for research.
And it puts American companies at this huge competitive disadvantage globally. You're paying so much more to insure their workers than their competitors in other countries.
But it's the personal cost that really drove the urgency.
Oh, absolutely. Look at the decade from 1999 to 2009. The average American salary went up 38%.
Which sounds okay.
Right. But in that exact same period, health insurance premiums, just the cost to get in the door, went up 131%.
Wow.
So even if you had a job, you were losing ground financially every year just trying to keep your coverage.
And the worst case scenario was just devastating.
Medical bankruptcy. Almost 700,000 bankruptcies a year were because of excessive medical bills.
And this is the part that's so shocking. Over 75% of those people who filed for medical bankruptcy had insurance when they got sick.
That's the crucial detail. It wasn't just the uninsured. People with private insurance were going bankrupt because of high deductibles or lifetime caps.
It led the source material to say, just about anyone could be one bad diagnosis away from financial ruin.
The system was financially toxic, even for the insured.
Moving on to the societal issues, we see this failure of access through the lens of disparity.
Yeah, the Institute of Medicine did a lot of work on this.
Right.
And the gap between the insured and the uninsured was just massive.
The numbers are stark. Adults without insurance were almost 3 times more likely to just skip needed medical care, even if they were really sick.
And for kids, it was even worse. Uninsured children were 7 to 10 times more likely to not have a regular doctor.
So this gap was just getting wider and wider.
It was. And that harms everyone's care in the long run.
Yeah.
Which leads directly to the concept of cost shifting.
The hidden healthcare tax.
Exactly. The mechanism is really simple. Because uninsured people avoid preventive care, they often end up in the emergency room with a late-stage crisis.
Which is the most expensive place to get care.
By far. So in 2008, the uninsured got about $116 billion worth of care. But almost $43 billion of that went unpaid. That's uncompensated care.
So where does that cost go? The hospital has to eat it.
No, they shift it. It gets shifted to taxpayers through higher government costs, and it gets shifted to private insurers, who then pass it on to you in the form of higher premiums.
How much higher?
The estimate was that this cost shifting added about $1,100 more per year to the premiums of every single insured person.
So you're paying a hidden tax to cover the failure of the system.
You're paying twice. Once for your own policy, and again to subsidize the uncompensated care.
Okay, so we're spending all this money, but what about the outcomes? This brings us to the health outcome issues.
And this is where it gets really damning. Despite spending the most money in the world, the U.S. lags behind almost every other wealthy country in key health metrics.
And the big differentiator is access to care.
It's access to primary and preventive care. Let's just run through the numbers. Out of 19 wealthy countries, the U.S. ranks 19th in overall mortality rates, dead last.
We have the worst survival rate after kidney transplants.
And for infant mortality, we're 23rd out of 23 wealthy countries.
That's just awful.
It is. Even our life expectancy growth is lagging. Between 1960 and 2010, U.S. life expectancy went up by 9 years. The average for other developed countries was 11 years. We're losing ground.
And part of it is a supply issue. We just have fewer doctors per person than the average.
And we can't ignore lifestyle, especially the obesity crisis. We have the highest adult obesity rate in the developed world, which just guarantees higher future costs for things like diabetes and heart disease.
Finally, we get to the moral and ethical issues, which for many people were the most powerful drivers for change.
And it all boils down to that one question. Is healthcare a basic human right, or is it a commodity you buy and sell?
The WHO, the AMA, the ANA, pretty much every major religion says it's a human right.
Yet in the U.S., the source says over 20,000 people a year were dying from treatable problems just because they didn't have insurance.
Which raises these huge ethical questions, like, should we allow private companies to profit from providing basic health care?
The U.S. is the only wealthy industrialized nation that does.
Yeah.
Other countries might allow profit on, cosmetic surgery or sophisticated services, but not basic care.
But the public outrage really exploded when the details of the shady insurance practices started coming out.
This is where you see the total regulatory failure of the old system,
We're talking about things like junk policies
right? Plans with low premiums, but these massive hidden limitations that left you totally exposed if you actually got sick.
and lifetime caps. Imagine having a chronic illness like hemophilia, and one day you just hit the maximum your insurance will ever pay.
You lose your coverage, you lose your job, you're forced onto Medicaid. It was a constant threat.
But the most egregious, the most unethical practice was rescission,
Rescission. The cancellation of your health insurance policy after you get sick.
based on some tiny pretext.
Exactly. Companies develop these sophisticated systems to go back through your original application and hunt for any tiny error or omission, anything they could use to cancel your policy and avoid paying for your cancer treatment.
And we know this was an industry-wide practice because of a 2007 court case.
But that case revealed internal documents. Just one insurance company avoided paying $35.5 million in medical bills by revoking about 1,600 policies over 6 years.
And they incentivized it. The employees who canceled policies got bonuses for hitting savings targets.
It wasn't an accident. It was an intentional, profit-driven strategy to drop their most expensive customers right when they needed help the most.
This led to a congressional investigation in 2008, and the findings were just appalling.
They found companies were rescinding coverage for typos, for failing to disclose minor conditions people didn't even know they had.
And the coldest one, they used computer algorithms to specifically target women who had just been diagnosed with breast cancer to find a reason to cancel their coverage.
The human cost of that is just. It's
So unimaginable.
you get the worst news of your life, and then your insurance company, the one you've been paying for years, tells you you're on your own.
And the reason this all kept happening was regulatory failure. The congressional committee concluded the individual insurance market was fundamentally flawed and that state oversight was just completely inconsistent and ineffective.
So you had the cost crisis, the bad outcomes, and these profound ethical breaches. All of it created this overwhelming mandate for comprehensive federal reform.
So what does this all mean for the actual policy solutions? Well, the ACA debate got so heated because the proposed solutions and the ideologies behind them are just fundamentally at odds.
Let's start with the progressives, who are mainly Democrats. Their starting point is that healthcare is a public good.
Like education or Social Security?
Exactly. They believe that for-profit industries will never, ever voluntarily sacrifice profit for social needs like universal access. So the federal government has to step in and run big social programs to make sure everyone's needs are met. They just fundamentally fear the profit-driven private sector.
And on the other side, you have the conservatives, mainly Republicans. They argue from a position of individual liberty and the free market.
Their core fear is too much government control. They believe it leads to abuse of rights, higher debt, and it stifles innovation. They champion the free market, believing competition and consumer choice are what drive efficiency and quality.
It is important to point out, though, that the source says there were a few points of agreement.
There were. Both sides agreed that no perfect system exists anywhere in the world, that reform had to happen, and that whatever we did, it had to stop taking an ever bigger slice of the economy. They agreed on the problem, just not the solution.
Okay, so let's dive into the specifics, starting with the proponents of the ACA. Their core belief, as you said, is that healthcare is a public good.
And their goals were to increase access by removing all those barriers we just talked about, improve quality with national standards, and lower costs by focusing on preventive care.
Let's run through the key features they championed, starting with expanded coverage.
The first thing, in 2010, was letting young adults stay on their parents' plans until they turned 26.
That was hugely popular.
It was. But the big expansion came in 2014 with the expansion of Medicaid eligibility. The estimate was that this would ensure about 32 million new people by 2019, a game changer.
And then there was the direct response to all those unethical practices, consumer protections.
This was a massive win for patients. The law mandated guaranteed issue, which means insurers had to cover you regardless of pre-existing conditions.
No more being denied for having asthma.
Right, and it completely outlawed rescission. And critically, it banned annual and lifetime caps on coverage, protecting people with chronic illnesses from going bankrupt.
The ACA also had these administrative regulations, like the medical loss ratio rule.
The MLR rule, yeah. This was a direct break on profiteering. It said that insurance companies had to spend 80 to 85% of your premium dollars directly on medical care.
So it limited how much they could spend on marketing, executive salaries, and profit?
Exactly. And it banned them from charging women more than men or charging more based on pre-existing conditions.
And for quality and cost control, they created the Independent Payment Advisory Board, or IPPA.
IPB was a huge point of controversy. It was this board of unelected experts appointed by the president whose job was specifically to recommend ways to contain healthcare costs.
Proponents said it was necessary because Congress just didn't have the political will to make the hard choices.
Right. And the law also started tying hospital and doctor payments directly to quality outcomes. That's VBP.
Hmm.
And it started closing that Medicare Part D donut hole, which saved seniors billions on prescriptions right away.
So for proponents, the ACA was this absolutely necessary, ethically driven law that finally put patients first.
But that required a huge level of government intervention, which brings us to the very strong counter-arguments from the opponents of the ACA.
Their core belief is that healthcare should be a service you buy and sell in a competitive free market.
And their main argument was about efficiency. They'd say, look, 85% of people already have insurance, and they're mostly happy with it. So why are we overhauling the entire system for everyone instead of just using targeted fixes for the 15% who are uninsured?
The biggest cited drawback was government control.
Yes. Opponents feared the law just transferred all this power to unelected federal bureaucrats. They argued that would reduce competition and innovation, the very things that make the American system great. They saw things like IPP as undemocratic.
And they had huge concerns about the economic effects.
They predicted it would slow economic growth, suppress wages because employers would cut hours to avoid the mandate, raise taxes on small businesses, and just blow up the federal deficit with a huge new entitlement program.
They also worried about the workplace effects.
They did. They argued the employer mandate would force employers to collect all this detailed personal data about their workers' households, and that the costs would encourage a lot of businesses to just drop coverage and pay the penalty.
What about the arguments regarding Medicare and Medicaid?
Opponents pointed out that the law cut payments to many Medicare providers while at the same time mandating this huge increase in Medicaid coverage. They argued that would threaten seniors' access to care because fewer doctors would be able to afford to take the lower reimbursement rates.
There were also states' rights concerns.
A big one. Opponents saw the ACA as an assault on the state's traditional right to regulate their own insurance markets. And they worried about being stuck with these massive unfunded mandates from Washington.
And finally, there were the public and ethical concerns from the conservative side.
They argued the individual mandate was unfair because it forced young, healthy people to pay higher premiums to subsidize older, sicker people. They also had religious objections to being forced to buy coverage for procedures they opposed, and they feared that care decisions would end up being made by distant bureaucrats instead of by families and their doctors.
So instead of the ACA, what were their proposed alternatives?
It was all based on free market solutions. Things like providing individual tax deductions for buying private insurance, allowing insurers to sell policies across state lines to increase competition, promoting health savings accounts, expanding state high-risk pools, and medical malpractice reform.
So it's a clear conflict. Proponents saw a market that had failed and needed federal oversight. Opponents saw a federal solution that was economically destructive and a violation of individual liberty.
Before we get into how the ACA was structured, we really have to look at the official position of the biggest voice in the health professions, the American Nurses Association, the ANA.
The ANA has been really consistent on this since 1991. Their core belief is that healthcare is a human right.
Unwavering on that point. They believe everyone deserves access to affordable, high-quality care. And their main goal is to invert the pyramid of priorities.
What does that mean, inverting the pyramid?
It means we have to shift our focus and our money away from the expensive, high-tech, hospital-based services that eat up most of the budget.
And redirect it where?
Toward community-based, primary, and preventative services. This is the model where nurses, especially APRNs, are the most effective and the most cost-effective.
And what's the ANA's ultimate goal for how we should pay for all this?
The ANA supports a single-payer mechanism as the most desirable option. They believe that's the best way to get universal access, control costs, and prioritize public health over profit.
So how did the ACA line up with that agenda?
Well, the ACA addressed a lot of the ANA's goals. It tried to move the system toward being more client-centered and preventative, but it fell short on their two biggest goals. The ACA does not explicitly declare healthcare a human right, and it did not create a single-payer system. It was a compromise that kept the private insurance structure largely in place.
And that compromise was incredibly complex. The term ACA is actually the original PPACA modified by the HCARA of 2010.
And the result was this massive piece of legislation, 487 sections, 906 pages, plus thousands of pages of regulations. It's not a simple law because it's trying to tweak and regulate so many different parts of the existing system.
To get a sense of the scope, we should look at the 10 major titles or sections that make up the law.
Right. Title I is where you find the core regulations, like guaranteed issue and the insurance exchanges. Title II deals with public programs, mainly the Medicaid expansion.
Title III is all about improving quality and efficiency, which is where you find VBP. Title IV is focused on prevention and public health.
And Title V is crucial for our listeners. It's about the healthcare workforce. It had provisions for nurse training, the National Healthcare Workforce Commission, and funding for nurse-managed health centers. All vital stuff.
And other titles dealt with transparency, and Title IX covered how to pay for it all, the taxes and funding. It's important to know about these titles because later, Congress would attack the law by just defunding specific sections.
Like the one supporting the nursing workforce.
Exactly.
Now, let's look at the implementation. For all the political fighting, there were some immediate successes.
Yeah, the closure of that Medicare Part D donut hole was a huge immediate win. It saved millions of seniors billions of dollars on their prescriptions right away.
Plus, you had the free preventive services and that super popular rule letting young adults stay on their parents' plans.
But the rollout of the state exchanges in late 2013 was, well, a mess.
It was a disaster. The software didn't work, the websites kept crashing. For a while there, it looked like more people were losing their old plans than signing up for new ones.
But it did eventually get on track. By the end of March 2014, over 8 million people had signed up, which met the original goal.
True, but state resistance has been a defining feature of the whole thing.
What were the states resisting?
Mostly the financial obligations. The ACA said states had to either create their own exchange or use the federal one. By 2014, 26 states had refused to create their own, mostly because of political opposition and fear about the future costs, especially the cost of expanding Medicaid.
And this brings us to the most controversial part of the law, the individual mandate.
The mandate is one of the three legs of the stool that holds the whole ACA up.
Okay, explain the three-legged stool.
The first leg is guaranteed issue insurers have to cover everyone. The second leg is subsidies. The government helps people afford the coverage. And the third leg is the individual mandate. Everyone has to buy insurance.
And why do you need all three?
Because without the mandate, young, healthy people will just wait until they get sick to buy insurance. That's called adverse selection.
And then the risk pool is only full of sick, expensive people, and premiums skyrocket.
It's a death spiral. You have to have the mandate to keep the risk pool broad and keep premiums down. The three legs are completely linked. You can't have one without the others.
And the political irony is that the individual mandate was originally a conservative idea from the Heritage Foundation.
It was. It was framed as personal responsibility. The political opposition only hardened once it became part of a democratic law.
And the opposite backs up the three-legged stool idea. Studies showed if you removed the mandate, premiums would have shot up by about 27%, and way fewer people would have gotten covered.
If you remove the mandate and the subsidies but keep guaranteed issue, the whole market just collapses.
We should also briefly touch on the use of waivers and funding gaps. The ACA had waivers for certain groups and plans.
Right. It's important to note that illegal immigrants were specifically barred from getting coverage or subsidies under the ACA. That was a clear policy line.
And the funding challenges are probably the biggest threat to the law going forward.
Absolutely. Congress still holds the purse strings. And many parts of the ACA, especially the parts in Title V that support the healthcare workforce, have had their funding cut or completely eliminated.
Like the National Healthcare Workforce Commission.
They were appointed, but Congress just refused to give them any money to operate, so they couldn't even meet.
And funding was pulled for nurse-managed health centers, which are key to that whole shift to community-based care.
It shows how even a massive law can be chipped away and undermined through the budget process.
So looking ahead, the biggest challenge is still cost control. Did the ACA really do enough to control costs?
That is the central question. A lot of people believe that when the public option, a government-run insurance plan that would have competed with private insurers, was taken out of the final bill, we lost our best tool for cost containment.
So we're left relying on things like VBP and iPay, which are always under political attack.
Right. And another huge ongoing challenge is public health and literacy. The ACA tries to shift focus to prevention, but we have this massive obstacle. 90 million adults in the U.S. have limited health literacy.
They struggle to understand basic medical information.
And now you've added 16 million new people to Medicaid, many with limited education, and you're asking them to navigate this incredibly complex system of forms and coverage options? If they can't navigate it, the whole thing falls apart.
And nurses are on the front lines of trying to bridge that health literacy gap every single day.
They are.
So finally, let's talk about the opportunities for nursing in this new landscape.
The ACA created this huge shift in demand that really only nurses can meet.
So more demand for APRNs as primary care providers.
More than ever.
Yeah.
And you'll see more roles in nursing informatics, in case management, and as nurse navigators, helping all those new patients find their way through the system.
But the biggest takeaway for nurses has to be the need for constant, vigilant involvement, especially at the state level.
Yes. That's where the battles over scope of practice are fought. Federal policy can expand coverage, but state policy decides who gets to provide that care.
So nurses need to educate themselves, get involved in outcome analysis, and join professional organizations like the ANA to make their voice heard.
Given that they're the most trusted profession, the collective political voice of nurses is incredibly powerful and absolutely essential for shaping what happens next.
Okay, so as we wrap up this deep dive, let's just quickly revisit the core takeaways. We started with this overwhelming economic urgency. Costs were out of control, causing hundreds of thousands of bankruptcies a year.
And that led us to the ethical imperative for change, which was driven by these scandalous insurance practices like rescission and lifetime caps. That proved we needed strong federal consumer protections.
And we saw the complex, two-sided nature of the ACA. For proponents, it was a social good that delivered vital protections. For opponents, it was government overreach that would hurt the economy and take away choice.
And the nursing profession, armed with all this context and these facts, is really mandated to be a full partner in analyzing what works and what doesn't as we move forward, making sure the system moves toward value, not just volume.
Let me leave you with this final provocative thought. It builds on those really depressing health outcome stats we talked about. The U.S. lags behind every other wealthy nation in things like mortality rates and life expectancy, even though we spend 2.5 times more.
Right.
Our source points out that the countries with better outcomes all have something in common: a higher ratio of social spending to health services spending.
In other words, they spend more of their money on things like housing, poverty reduction, nutrition, and education than they do on high-tech medical treatments.
So the question is this: what does it mean for the future of U.S. healthcare if the ACA successfully gets 32 million more people insured, but we continue to spend disproportionately less on the foundational social determinants of health? Can we really move the needle on life expectancy and infant mortality without changing that fundamental ratio?
That question shifts the whole debate, doesn't it? It moves it from just being about insurance to being about what truly creates health in a population. And that's a debate that will definitely define the next generation of health policy.
Thank you for joining us for this crucial deep dive into the complex and continuing debate over healthcare resource allocation.
We encourage you to keep learning, get involved, and keep advocating.